respected chairpersons, teachers, and my dear colleagues. I am Dr. Anilkumar from a small charitable trust hospital in Uttapalam, presenting before you an innovative method of CRPP. First of all, I thanks to Dr. Ramohan for his words, and I intended to KOA for giving me an opportunity to pursue my research and focus my findings in the form of this Golden Jubilee Oration 2022. I am extremely grateful to my teacher, Professor Cherian Thomas. The technique of CRPP was first introduced by Lambert in 1908. Presently, CRPP is applied only for simple and extra-articular fractures. I started the technique of CRPP from 1990 onwards without CM. At that time, the hospital could not afford that one. Later, we purchased one. I had modified the fixation several times from 2004 to 15 and presented the same in the conferences of IOA, KOA, and IASIS. After 2015, I presented the technique of CRPP in the conferences of more than 10 renowned world orthopedic associations like AOAS, BOA, APOA, SICOT, Singapore Orthopedic Association, American Society of the Hand Surgery, and International Colloquium. The method of study is, it was a prospective study of 20 types of fractures which were grouped and studied separately in 20 groups. A total of 1,108 cases were selected for a period of 10 years. The type of fractures undergone CRPP and the demographic of the patient is given in the chart. Regarding the general outline, anesthesia is regional anesthesia, rarely short GA. The procedure is different for different fractures. The intra-articular fracture distal radius, all type of intra-articular fracture distal radius can be treated by CRPP. The intra-articular fracture distal radius is reduced by a modification of the existing technique, where there is a distraction done with the surgeon with a counter-traction manually, and after that the hand is transferred in distracted position in 2 stages, and AP compression is given for the major fragments, and milking technique is used for the small comminuted fragments, and which is done towards the RC joint. And finally, the repositioning of the radioulnar joint is done. Regarding the pinning technique, the fixation is done by creating 2 triangles in 2 planes through the outer cortex using 6 KOAs. First KOA from the radial styloid, second from the lateral surface of the proximal fragment, and third wire transversely from the ulnar head to the radial styloid, parallel to the radial articular surface through the subchondral board. 3 more KOAs are used for additional fixation of the fragments in a different plane according to the fracture configuration. The ends of the KOAs are bent at 90 degrees and buried into the subcutaneous plane, and a POP slab is given for 4 weeks. These are some examples. This is a 21-year-old bike racer, returned to his bike racing at 1 year with a bag of wounds. He approached me. This is a 34-year-old female. This is a 73-year-old female. This is a Barton's fracture. This is a 43-year-old man with a Barton's fracture at 3 months. The range of movement you can see. CRPP can be applied successfully in the type 3 and 4 supracondylar fractures in children. Complicated fractures with intercondylar and bicondylar fractures were first fixed with 1 or 2 transverse wires. 99% of the supracondylar fractures with absent radial pulse were regained on completion of CRPP. The close reduction done in 3 steps. The positioning of the fractured limb for distraction without creating iatrogenic neurovascular complication, and distraction with or without compression, and the reduction, and the hand is transferred to the second assistant. The persistent pressure applied over the medial epicondyle with a finger for shifting the edema fluid for feeling the ulnar nerve from the medial epicondyle, and ulnar nerve is pushed backwards with the thumb for creating a safe entry point through the medial epicondyle. The 4 wires are used, 2 from each side, and the wires are bent and placed in the subcutaneous plane. These are the screenshot This is a 10-year-old boy with a severely comminuted supracondylar intercondylar fracture, and this is the end result of the 6 months. Both right and left elbow is shown for comparison of the results. This is an 11-year-old boy with a supracondylar fracture elbow at 3 years. Here also the unaffected limb is also the X-ray shown here for comparison of the results. This is a 6-year-old girl with a supracondylar fracture, right elbow, and at 9 months the radiological and clinical findings you can assess from the video. This is a 7-year-old girl with a flexion type of supracondylar fracture, right elbow at 3 months. This is a medial epicondyle fracture at 6 months, treated by the same method. Right and left elbow is shown for comparison. This is a 20-year-old male with a lateral condyle fracture with a dislocation of the elbow at 6 months. In adult, 1.8 mm KOA is used for fixation. For interfragmentary compression, one or more cannulated cancellous screws are used here. This is a screenshot. This is a 50-year-old man with a supracondylar fracture at 6 weeks. This is a 65-year-old lady with a supracondylar intercondylar fracture, undergone CRPP and also PCCS. At 3 months, the result, and one screw is used there. This is a 66-year-old lady with a supracondylar fracture at 6 months. Here there are 2 cannulated cancellous screws in addition to the pinning is done here. The reduction is done by traction, counter-traction in pronated position for the fractured scaphoid, and the wires are introduced percutaneously. This is 22-year-old man with the fractured scaphoid. It's a delayed presentation. Bennett fractures also can be treated by CRPP. These are the screenshots of this Bennett fracture fixation. This is some examples. And metacarpal fractures also can be treated with the same method of cross pinning. This is a 19-year-old man. This is a 36-year-old man with head. This is a shaft of the metacarpal which is fixed. And phalangeal fractures also fixed with the same, the screenshots. And this the fracture distal third forearm can be easily fixed with the CRPP and varying distance by cross pinning, both in adults and children. Mondegi and Calasia fracture dislocation can be treated in combining with the CRP-IM and with the CRPP. Early return to the normal activity without deformity is in the children. Screenshot of the CRPP in pediatric case. This is a 16-year-old boy, technically compound, both bones, distal third fracture, where the ulna is double fracture, the epiphysis is gone along with the radius. And this is a 6 months result. The X-ray is also shown here. This is a 14-year-old boy with fracture both bones. This is a 74-year-old lady. This is a 64-year-old man and 30-year-old man with Montague fracture. Here, the percutaneous pinning and CRP-IM and nailing is also done here. This is a 32-year-old lady with a comminuted Galeazzi fracture. And close reduction done by traction, counter-traction technique for fracture radial head. This is a screenshot of the pediatric Montague fracture with the radial head. This is 9-year-old isolated radial head. The fracture proximal humerus treated by CRPP, both in adults and children by crossed KOAs. Fracture distal third humerus in children were successfully treated by this method. These are the screenshot. This is a case. This is a 6-year-old boy and 74-year-old lady with the proximal humerus. This is a proximal humerus cross pinning, pediatric, and then we are going to lower limb. The CRPP can be applied to all kinds of ankle fractures, even with emerging soft tissue complications. The POP slab is given for 10 to 12 weeks, weight bearing after 8 weeks with POP, cover is removed at 14 to 16 weeks. This is a procedure. Distraction is done by traction, counter-traction taken manually, transfer of the foot to the second assistant, and clinical judgment by palpation and fine correction and proceeding for fixation without imaging. Fixation is done by multiple KOAs depending upon the fracture configuration. Most of the cases, lateral malleolus fixed first. That's the first set. Second set, we are fixing the medial malleolus with the minimum of 2 KOAs. And third set, if required, the syndesmotic joint will be fixed with the 2 or more KOAs transversely from the fibula to tibia, crossed in diverging manner with an angle of 30 degrees, and stability is checked, and after that The cavers are bent at 90 degrees and placed in the subcutaneous plane, and POP slab is applied for 8 to 10 weeks. These are the screenshot of the lateral malleolus fixing first. This is medial malleolus fixing first. This is a 58-year-old lady with a type C ankle fracture at 4 months. All the crossed cavers were removed before that. And this is a 59-year-old lady with a trimalleolar fracture at 6 months. The X-ray of both injured and uninjured limb were shown at 6 months. This is a 66-year-old lady with a trimalleolar fracture at 6 months. You can see the ankle movement and the end results. The X-ray is also shown there. This is a 13-year-old girl with a fracture dislocation of the ankle at 1 year. This is a 40-year-old lady with a posterior malleolus fixed in the CRPP from posterior to anterior direction. This is the end result at 6 months. This is a 22-year-old football player with a type C ankle fracture, and this is the end result. He returned to his job within 6 months and performed in the March match after 1 year. This is the X-ray of both limbs. This is a 67-year-old lady after 3 years. The gait and also the ankle movement. You can see. This is a 15-year-old man with a pylon fracture. You can see this deformity, and this close reduction is done with the traction, manual traction, and the fracture is fixed with the shaft, and anteroposteriorly it is fixed with the another two cavers, and high fibula fracture is fixed percutaneously by cross fixations, and stability is checked, and the end of the wires are bent at 90 degrees and kept in the subcutaneous plane, and a POP slab is applied. When the soft tissue conditions does not permit ORIF, when we go for CRPP for fracture distal third leg including tibial plafond fractures, we can fix it with CRPP. The fracture, this is an example of 54-year-old lady with fracture both bones, right leg, lower third. This is an X-ray. The video is not shown. This is a 34-year-old male with a severely comminuted fracture both bones, and this is a 15-year-old lady comminuted lower third both bones leg. This is a 48-year-old male at 6 years. This is a 60-year-old lady with a fracture both bones, right leg, CRPP and PCS is done. And this is a 40-year-old man with fracture both bones leg with ischemia came from a bone setters, and multiple cavers are used for this. High energy bicondylar fractures are often accompanied by soft tissue damage, which in turn delay the ORIF or contraindicated. In some situations, CRPP alone or with PCCS can be done to reduce the complication and to avoid the staged treatment. The POP slab is applied for 10 to 12 weeks, and this is a 32-year-old man with a proximal third leg. The X-ray of both injured and uninjured limb at 4 years, and the range of movement in the front is visible from the still photograph and also from the video. This is a 52-year-old man with a tibial condyle fracture with a severe local ischemic conditions. It's a severely comminuted, and the tibial condyle on completion of the CRPP with the multiple screws, and the same man at 6 months, and the range of motion, and also the cavers are removed before 4 months. The screws will be removed only after 1 year. Foot fractures which need surgical treatment including Lis fractures and fracture talus and calcaneus can be fixed by CRPP. These are the screenshot of CRPP of metatarsal injury. This is a Lis fracture fixed. This is a 39-year-old man with at 4 months. This is a 39-year-old lady at 3 months with foot fracture. This is a 30-year-old man at 3 months. First metatarsal is severely comminuted. This is a 27-year-old man with a fracture talus, and this is another talus. This is a calcaneus, and this is a 70-year-old man with calcaneus fracture. In developing country like India, close reduction plaster casting has a major role in the treatment of fractures. The cost of treatment becomes unaffordable for the common man, especially when he needs a surgical treatment. Here lies the significance of the modified CRPP as a common man's effective patient-friendly surgical treatment. Presently, CRPP is used only for certain simple and extra-articular fractures. But the modified CRPP can be used here. In certain fractures, its modified CRPP claimed a particularly good result, even better than the present methods of surgical treatment. One among them is CRPP for the intra-articular fracture distal end of radius claimed a superior result than any other method. The innovative technique was accepted and included in the video theater of the AOS study material through annual conference, and CRPP of intra-articular fracture distal radius published in the journal, and I got the third best paper award in the second joint scientific meeting of American Society of the Surgery of the Hand and Singapore Society of the Hand at Singapore. These are the highlights. Whenever there is indication for surgery in a particular fracture in and around the metaphysis, we can apply CRPP. Complicated intra-articular fractures, which were thought to be reducible by closed methods, are treated by modified CRPP. When RIF cannot be done or postponed due to soft tissue edema and threaten the impending soft tissue complication, we can apply CRPP. And there is no skin incision is needed, no implants projecting outside, so immediate joint movement is possible from the next day onwards. And CRP can be done in a peripheral hospitals also. The relevance, excellent results were grabbed by CRPP in type 3 and 4 supracondylar fractures in children. In doubtful vascular injury cases, return to the radial pulse with a good capillary flow immediately after completion of CRPP on the table, which avoids unnecessary vascular exploration and complications faced thereafter. Excellent results were obtained in type C ankle fractures, including pylon fractures, especially when RIF cannot be done. Hand is a main tool of the common man for their earning capacity. Hence, the amount of disability following the treatment of fractures of the hand is accountable. Hence, both the neglect of a small fracture or more aggressive treatment without giving importance to soft tissue structures leads to their reducing their earning capacity. Here comes the role of CRPP. Even though the gold standard treatment for the proximal third leg fracture is RIF, sometimes it cannot be done or may be delayed due to impending soft tissue complication. Here we can apply CRPP. Same is the case for the fracture distal third leg also. Regarding the complication, pin loosening and pin migration, one of the commonest complication can occur in osteoporosis and severe combination, and pin breaking can occur in heavy loading, and skin necrosis and infections are very, very rare, and RSD is negligible, and residual deformity occurs in early over. The results were analyzed based on the clinical and radiological findings of individual fractures. The consolidated group result of the type of fractures are there. Conclusion, like the scaffolding in cement concreting, the metallic frame created with the multiple cavities piercing from both the cortices, crossing inside the medullary cavity and encircling the metaphysis, maintain the longitudinal alignment and prevent the metaphyseal collapse and thereby articular congruity. Recent literature shows that specific technique is not important as aligning anatomical reduction. Clinical outcome and biomechanical studies demonstrate that maintenance of the anatomical reduction is the most important factor in obtaining good results. These are my references, and thank you. Thank you very much.
Thank you, sir, for that informative talk on innovative technique of managing common fractures we deal in day-to-day practice. Thank you, sir.
Thank you very much.